Hey, gorgeous. Welcome to Season 2 of the Hormone P.U.Z.Z.L.E Podcast. I'm your host, Coach Kayla Smith, CEO of the Hormone P.U.Z.L.E Society, a women's health hub for fertility, hormones, and the business of coaching, creator of the Hormone P.U.Z.L.E method, an infertility warrior, two-time boy mom, and women's health expert. This podcast is for women struggling with infertility, painful periods, terrible PMS, or really just any symptom of hormone imbalance that they are ready to eliminate for good. Tune in weekly as we interview amazing experts in the fields of women's health, breaking down those hormone walls, nerding out on nutrition, and having way too much fun. Whether you're beginning your journey or you've been struggling for years, we're going to finally help you put those pieces of your hormone puzzle back together so that you can get pregnant and eliminate those pesky symptoms for good. Are you ready? This season is packed with even more expert guests sharing groundbreaking knowledge, giving you that jolt of energy that you so desperately need, sending you lots of virtual hugs, and inspiring you to take your fertility into your own hands and make that baby. Thank you so much for tuning in. Now let's get started on your road to transformation. Dr. Danielle Lane of Lane Fertility Institute is a highly regarded reproductive endocrinologist and fertility specialist who provides fertility services for residents of the San Francisco Bay Area, as well as telehealth services. We had a wonderful conversation about many areas of fertility, how to boost your fertility naturally, how to be your own health advocate, as well as about a new, less expensive alternative to IVF. You do not want to miss this episode. And you might also know Dr. Lane from her cute little dance videos on TikTok and Instagram. Let's welcome Dr. Danielle Lane to the show. Hey, Dr. Lane, welcome to the show. Thank you so much for being here.
Well, thank you for having me. Very excited to join you and talk to everybody on the Hormone P.U.Z.L.E.
Yes. And happy new year. Welcome to 2021.
I know, right? We are all excited for this to be an uptick from last year.
I know. I'm like, we cannot go down any more than we have. It's got to go up from here.
I agree. I'm always afraid to say quite that, but I do in theory agree with you.
Right. Don't want to jinx anything, but
no.
Well, awesome. Well, thank you again for joining us, and just tell us a little bit more about you and, who you are and how you got into women's health.
Sure. So I am a reproductive endocrinologist and infertility specialist. So that's a long word, but the reality is most of what I do is fertility work, helping people get pregnant. And I got into this field. I mean, the standard approach in the world of medicine is an OBGYN residency, and then you can subspecialize into a variety of different things. And I wanted and still do feel pretty passionate about working with women that are trying to start their families and balance their family life with all the other things that we're asked to do as women today, right? Go to the moon, become the next vice president, run a business, right? And oh, by the way, can I stop and have some kids too? And so as a consequence of that, we see a lot of women who have really moved forward a lot of facets of their lives and not been exposed to the information around our reproductive biology and what it means to delay childbearing and what the consequences of that might be. So that's where I spend the bulk of my time, is working with those patients. We see a lot of women for whom they haven't delayed their childbearing and they're just having struggles getting pregnant as well. Equally as passionate about helping those women, but that's sort of the range of patients that I see.
I love that. I love it. And do you have your own story with fertility?
Not particularly. I mean, other than to say that I was, I was a young resident seeing a lot of patients that were struggling with fertility and was pretty passionate about wanting to make sure that I didn't find myself in that boat, at least from an age-related fertility issue. So I started children relatively early. I mean, I have 5 kids.
Oh my goodness. I did not realize that. I do see your daughter dancing on Instagram, so that's fun.
Yeah. Mackenzie's 7, so she's still, interested in doing anything that mommy's doing. But, next daughter up is 14, and then we have twin girls that are 17, and then we have a 20-year-old son.
Oh.
So, I was 28 with my first child and 41 with my last. And so, I didn't find myself needing to go down the path of much of what I treat people for. But the reality is that, some of that was because I was blessed to be in a space where I got a lot of information at a very important and impactful time. I think the story that I will be able to tell people, though, is the balance of that with then trying to have a career, right? Because, it seems that the choice is either that you just sort of focus on your career and then you end up in my office, or you have kids at the time that biologically is a lot easier for us, but then you're struggling with all of the messaging around what it means to have taken the path of doing that versus just being a straight career person. And I think that's always very interesting.
For sure. And I love you dancing on Instagram. Tell us a little bit about that. What was kind of the inspiration? Because I think it's brilliant. It really grabs my attention. And I know women's health, and I'm like, I didn't know that. That's so cool. And it's because you're dancing that I pay attention to it.
Oh, that's so funny. Well, I'll remember to tell that to Janae, because sometimes she's like, you dance too much. I'm like, all right, well, I guess we could just sit and talk and do a flat video. Boy. Anyway, so March, I will tell you that before March of 2020, I literally didn't know what TikTok was. And my Instagram was private, and, and I had it because my kids had put it on my phone, and I was like, okay, what's this Instagram thing? I still don't get Facebook. Like, Facebook confuses the mess out of me. But anyway, so we were sitting around in March, all looking at each other, all 5 of us in our, little tiny San Francisco, 2-floor condo. And my 14-year-old keeps dancing at her phone. And I'm like, what are you doing? Like, why are you dancing at the phone? Like, and then she would show me this little clip, and then she would do this dance. I'm like, really, like, literally, what are you doing? So over some time, they explained to me what TikTok was. And actually, the Instagram reels that you see are really just uploaded TikTok videos.
Yeah.
I actually find the TikTok platform a little easier to work with than the Instagram reels platform. Shh, don't tell them.
I agree with you.
Yeah, I just can't quite figure it out. But, that's sort of how it started. And of course, the challenges were that, one, I'm not a 14-year-old or a 16-year-old dancing on, social media. So it had to be music that was clean. There couldn't be violence. We couldn't use swear words. You couldn't talk about drugs. And the dance had to be easy enough for me to do. So you had to put all those facets together, and then I could get to the messaging, right? So it's gotten a little bit harder over time. For a while, I could post stuff off of Charlie D'Amelio or whatever that other, Addison Rae, whatever her name is. But, their dances have gotten more complex, and their music has gotten more, And so I'm not as, I don't know if I'm as creative as I used to be, but that's how it started. And there are a handful of physicians that have been on social media for a while in my space. But there's not a lot of diversity in those physicians. And one of the things that I think became very clear to me very quickly is that there are folks that need to see messaging from people that they feel like they can connect with, whatever that means to them, right? And I want to be clear, you will never hear me say that you should pick your physician based on their ethnicity. I think you should pick your physician because you believe that they're an excellent physician, right? But I also can appreciate the fact that for some people, it's important for them to hear that messaging from someone who they feel like they can trust, in addition to the fact that they better be excellent at what they do. So I think it's really been fascinating for me to recognize how many people feel like they just didn't have anyone to ask these questions to or get the messaging from, then I used to think, oh, I can't use that thing because someone else has already used it. And I realized that the, 60,000 people following me on TikTok are not the same as the 70,000 people following someone else on TikTok. And so, I can still use the same information, and they can use information from me, and we still get messages to different people, and that's still really important.
Mm-hmm. And I think it makes you very relatable. Like, I feel like, you could be a friend when I see you dancing on TikTok. I'm like, oh, I want her to be my doctor. I think it gives that little bit of personal touch that I think is missing in a lot of physicians' offices. So
I think that's, And it's really interesting to me because, I'm probably the biggest introvert you'll ever meet. Like, if it was that was on a screen, I
I never did a live video until
Yeah.
I got on social media. Never.
Yeah.
It's like,
Right. And I still don't do live videos. I do videos in my house. I draft them. I like edit the mess out of them, and then I put them out. Right. And and I really don't. I mean, I will answer questions that patients have, but I rarely read through all of the messages on first pass. Like my kids usually do that. They'll be like, Mom, there's a bad one on here, or Mom, this person really needs you to answer them, and it's mainly because like I really am an introvert and I don't like the sort of hate stuff that some of these people have gotten on social media. Like I necessarily don't respond really well to that. So in order for me to keep doing it, I need to be able to do it, put out the messaging, talk to the people who have questions, and like just filter out the rest of it. And that seems to work for me. But yeah, I'm not, and I think you're right about the relatability thing. I do think that I hear a lot of patients who come to me and say, I talked to this doctor and I just couldn't get any connection with them, or I just felt like they weren't listening to me, or I just felt like, some of what's happened, at least in the field of fertility, is that, and I think you may know this, a lot of fertility practices have been rolled up into these big corporate conglomerates, right? And the problem with that is that, their purposes are different, right? And I'm not going to say that's true for every, because I've spoken to a couple recently that I thought, wow, I could merge with them. I could work with them, But I think that when you're trying to see, 100 patients a day at a time frame that you should probably be seeing 20, it gets to a place where it's hard to really give quality care. And I had a patient the other day who's like, I just don't understand. They haven't called me back. And I'm like, well, they're not going to call you back. They're doing 1,800 cycles a year. If you want their attention, you need to go call them. Right.
Right.
And, and that's sort of, if you will, the downside of large practices of, dollars and cents from corporations coming into the fertility space, and also of insurance. Now, I'm totally an advocate of folks having coverage and benefits for their fertility. But what I've noticed is that in some of these states where there's mandated insurance coverage, and the doctors they don't have to go out and look for patients. They don't have to, like, there will always be someone at their door for them to take care of. I think they're a little burnt out, right? I mean, I think that the doctors are good doctors. I mean, I know these folks; they're good doctors, but I think the model in which we practice, the model in which they practice, is different. I see people 3 days a week, right? And I, get to spend 2 days a week, like, trying to figure out how I'm going to clean my kitchen in the middle of a pandemic when I have no help, right? When my teenage kids don't want to get out of their beds. Like, I mean, and that balance matters, The flip side is I'm on call 24/7 for my patients all the time. So people call me at all hours and email me all the time, and I work weekends when I need to. And, sometimes that's like inconvenient for my family, but there's a balance to that I get to sort of still be the puppeteer of. And I think in some of these newer scenarios, that's not the case. And I think patients feel that. So I suspect that's why the relatability matters. And hopefully, people can get back to that relatability at some point. I don't know what the pendulum swing will be on fertility practices in this country, but
we'll see. And well, I'm glad there's more doctors like you stepping up, because that was one of the reasons I got into fertility coaching and doing my podcast, because I had my own struggles with infertility, and I went to one of those big conglomerates, and it was very move me through a system, not look at me as an individual. Like, you need to do this, 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 and this, and then you need to pay us this. You might get a baby, you might not. So.
Right. And I mean, I think, and it's interesting because, I'm not, and I don't want to get too far off the topics you want to cover. I'm not sure I am, I'm not an operations expert, right? And so I'm not sure that I have the skill set to necessarily know what the best model would be. But I think one of the things to consider is, a long time ago, the American Society of Reproductive Medicine put some guidelines on what they think the maximum number of cycles a physician should do is, right? And they're a little bit dated, no doubt. I think there are ways in which you can use mid-level providers and, augmenting ancillary services to help extend a physician's reach, but not the way that we've chosen to do it, right? And so I think that there are enough practitioners in this country that things could be balanced out a little bit more. And maybe that means that, one practice wouldn't be making, $60 million and another practice wouldn't be making 100,000, but like, maybe there'd be more balance in that, and maybe the $60 million people would not be happy with that. But I think that the patient care would be a little bit more leveled out. And that I think the physicians wouldn't be as burnt out, but patients would feel like they're getting more attention to detail. There'd still be a reason for systems, right? Because the regulations that are beginning to happen in the world of fertility are such that if you don't have systems, you'll miss things. And if you miss things, the flip side of the systems are the legal system in our country, and the fact that people turn around and they sue every other day, And so you can only put yourself out on a limb so far before somebody comes and says, but you didn't do it that way, so now I'm going to sue you. So there are all these little things pulling that make it really challenging, I think. But I think we can do better to adjust the model and just make sure that the patients are still getting the care they need in the space of all these extraneous things that are causing us to behave the way we do. So
I agree. Yeah.
Perhaps a model for our country. I mean, I'm just saying. Okay.
Yeah. Just saying.
I mean,
yeah. I love it. Well, let's switch gears a little bit. I try to give people really practical things that they can do on this show, either to boost their fertility naturally or to get a better outcome with an ART treatment. So do you have kind of 2 to 3 little go-to tips that you give to most patients so they can try to do this?
Yeah, I mean, I'd like to start with before they get to us, because I think that's really the biggest barrier. I think the biggest barrier, and this is one that I really struggle with, is that people feel like they need permission to get a fertility evaluation. Like, you don't need permission to go get a fertility evaluation. You may have to pay a couple $100, but like, you don't need anyone's permission to do that. Right? You don't have to wait for, someone to, refer you, or you just have to go do that. So if you are, and these statements, but people still show up not understanding these guidelines. If you're under 35 and it's been a year and you're not pregnant yet and you've been trying, which only means that you're not using protection, you need to go get a fertility evaluation, you and your partner. If you are, under 40 and it's been 6 months, you need to go get an evaluation, a fertility evaluation for you and your partner. And if you're over 40, you probably should start with that before you go just try, right? So, I mean, I think if we could do a better job of getting that messaging out to folks, I think we would, I feel like more people would be educated about their fertility before they were 18 months down the road, right? Having spent time that they shouldn't have wasted doing things that were going to be inefficient. So I think that's number one. Okay. Mm-hmm. My second tip to people is that if you have gotten a fertility evaluation and you've gotten a workup done, you need to demand that somebody explains to you the results of your information, right? Yes. Because the other thing I'm seeing is this trend of women who are like, I got an AMH level done and it was 0.48 and then I tried for 18 months and nothing's happened. I don't understand. And I'm like, so, I mean, I feel like if you go to that fertility evaluation and you get your testing done, you need to demand an explanation. And if you do not get the information that you need from that person, take your records and take them to somebody else and get the information that you need to understand what we've learned about your body, right? So get the evaluation, understand the outcomes of the evaluation. Mm-hmm. Then I think that I still think, and it seems very basic and mundane, but lifestyle matters, right? Now, I don't want people to think that lifestyle is going to fix their infertility or their subfertility or their fertility issue, right? Whatever phrase you want to use. The folks that come in and say, hey, I know I'm 40, but I'm a really healthy 40. So I don't understand why this is impacting me. Like, it's not like that's going to make the difference, but being healthy, making sure what you're putting in your body, makes sense matters. So a healthy diet, a balanced diet, minimizing, unnecessary carbohydrates, minimizing, maximizing the water and making sure you're hydrated, exercise, moving your body. And exercise, I love the people who come in. I had somebody the other day who was like, I don't exercise, but I walk to work and back and it's a mile each day. I'm like, no, that. Right. So moving your body, let's use that phrase, right? And killing the toxins, get the toxins out. So, you don't need to be drinking excessively because God knows we're all, in our houses with a lot of access to alcohol. Somehow alcohol was an essential, right? That was an essential service. Okay. But anyway, no alcohol, I'm not going to say no alcohol, but minimizing alcohol, minimizing caffeine, stopping tobacco, and no use of marijuana, which is now actually a legal substance in many, many states. And so we're seeing an upsurge in folks that are coming to us that are using large amounts of marijuana. We'll have data soon, but believe me, we won't like the outcomes, right? So I think those would be the three things that I would tell people. Get your evaluation early, right? Understand what you got from your evaluation, and then, and then make sure your body's in its best state of health. I think if you can do those three things, you will have better outcomes with your ART and with any of your fertility treatments because you'll understand what you should be doing, right? There's so many people who don't understand what they should be doing. Mm-hmm. I think the last thing that's out there that I really would want to point out is that, and I don't know how long ago your fertility journey was, but historically, as a part of a fertility evaluation, we used to look at the pelvis. We used to do a diagnostic laparoscopy to determine whether folks had obvious causes for infertility in their pelvis. The biggest one we're missing these days is actually endometriosis, right? And so I think that if folks have pelvic pain, body pain, pain with intercourse, pain with ovulation, dysfunctional period pain, like that's got to be a part of their mindset of thinking that, gosh, is this something that I should be evaluating for? Should we be looking at, endometriosis as a possibility? Maybe we'll see something on ultrasound like an endometrioma or hydrosalpinx. Maybe we won't, right? Maybe we'll be able to do a receptiva assay. Maybe you have enough time in your own, fertility journey, your 20, 22, whatever, that we can try a Lupron and see if it improves. Maybe you're talking about a laparoscopy, but we are missing a ton of endometriosis because we're just not looking anymore, right? And those women take a much longer time to diagnose than they should because of our systematic approach now, which differs, despite all of our systems, which differs from what it used to be and our easy access to that information.
Well, my story was 9 years ago is when we started struggling, and then my oldest is 7. So I don't remember getting any kind of testing like that. It was a lot of blood testing, a lot of, you need to do the dye procedure and the testing of my husband and all of that. But they never looked at my uterus, my cervix, none of it.
Yeah. So, I think that I started fellowship in 2002, and I would say by the time I was starting fellowship, we were no longer doing diagnostic laparoscopies the way we used to, right? So, and I get it. I really do. Nobody wants to go to the OR if you don't need to go to the OR, but there's a lot, we're missing it. We're really missing it.
And is that something you can request if you say you have any of those symptoms that you just mentioned? You can go to your doctor and say, I'm having trouble getting pregnant. I want to request this test.
Well, diagnostic laparoscopy is a surgery, but what you can do is say, I'm having trouble getting pregnant. Have we ruled out endometriosis? What are our options to do so, right? I think that's how I would phrase it, because there's more available than just doing, and sometimes you can get there on history, right? The patient may not believe you, but you can get there on history, in many cases. And so then, but it matters because then your treatment changes, right? Unexplained infertility is one path that may not require, in vitro fertilization. Endometriosis is another path that, I think we all believe that the outcomes are best if you approach it that way. And so understanding whether you're in that bucket or not 5 years earlier matters,
Gotcha. I love it. Well, let's talk about some procedures that you offer at your clinic. InvoCell was one that I saw that was very interesting to me. Tell us about that.
Super excited about InvoCell. I'm gonna grab my little InvoCell. Can I grab my InvoCell for you?
Definitely.
In love with my little InvoCell.
Yeah.
I'm the only one who keeps an InvoCell and 2 uteri in their kitchen.
I love that. And all of you on YouTube can look at this and see our fun little model.
Oh, my toy. Okay, so InvoCell. InvoCell is almost a return to a more basic form of in vitro fertilization. I think what we've learned over the years of IVF, certainly since I've been in practice, is that we can get very advanced in the technology that we have to do in vitro fertilization. We can optimize fertilization. We can optimize culture. We can optimize hatching. We can optimize just every condition in the lab. And when we do that, we certainly can improve outcomes over what we thought traditional IVF looked like. But we also get to a place where we can overdo things. And there was a study that came out in 2019 that looked at the fact that embryo biopsy was a really great benefit for some patients, but actually didn't improve outcomes in others. And the cut point was 35. So if you're under 35, there wasn't an improvement in outcomes. If you were over 35, it did improve outcomes because you could pick the right and select the right embryo to use, right? But the problem is that by the time you get to that level of in vitro fertilization, and you mentioned it, then they want your money, right? It's expensive. I mean, in the Bay Area, if you're doing in vitro fertilization with all of the bells and whistles, it can top off at $30,000 and above. And that's a lot of money, even in the Bay Area where, the cost of living, the minimum cost of the poverty line is about $109,000, which is also crazy, right?
Wow.
So, right. And so it was important to start to look at models in which you could provide in vitro fertilization like services, but at a lower price point, because we know that clomidine intrauterine insemination has success rates of about, 10 to 12% tops. We know that injectables and IUI have success rates of about 15 to 18% tops. And oh, by the way, the multiples rate is how John and Kate got 8, right?
Oh, wow.
And so if you want to be able to maximize pregnancy rates but minimize multiples, you need something that's in between that. You need something that is going to give you a good stimulation protocol, but not going to require you to have all of those embryos in your uterus. And that's where INVO-CELL comes in. So here's the INVO-CELL. It's this tiny little device, okay? And what you do is you stimulate someone's ovaries just as if you were going to do an in vitro fertilization cycle. You do an egg retrieval where you take out the eggs, right? But then instead of putting the eggs and the sperm into the incubator, you put them into this tiny little device, which goes into this carrying little cone. It's got a little top on it, and you load through that tiny little circle. I don't know if you can see the circle there. And then put that into this device like this.
Okay. Almost looks like a little contact case, how you
put
solution. Yep.
Right. And then and there's media in it, so there's solution. Okay. You put this entire thing into this diaphragm, and the diaphragm goes into the vagina. So it actually sits, if you look at this little thing, this is your uterus, your fallopian tubes, your ovaries, and here's your vagina. So this little container sits in your vagina below your uterus, below your cervix for 5 days. Then we take it out.
And you cut out just a little bit. I'm sorry, for how long?
Oh, sure. 5 days, right? So blastocyst. So it goes into the uterus, into the vagina, sits below the cervix, sits there for 5 days at home, okay?
Okay.
And you get to do whatever you need to do. You don't have to be on bed rest. You can go to work. You can, maybe you shouldn't do too many squats, but you know what I mean? And then you take it out. The lab extracts the embryo, and then you do a transfer into the uterine cavity.
Wow.
And now, depending on the number of embryos that you have and your age, you can apply ASRM guidelines to look at whether you should be transferring one embryo, which is almost always the right answer in 2021, excuse me, or 2 embryos, and rarely more than that. But that's what INVO-CELL is. And, the thing that's nice about INVO-CELL is that the price point is like a quarter of what I just talked to you about as it relates to, in vitro fertilization, right?
I love that.
Exceptions to why you might not use it. I mean, in the Bay Area, a lot of people have coverage for their IVF and their embryo biopsy through their jobs. And for those folks, sometimes it's more cost effective for them to make more embryos in a single retrieval and not have to go back through the stimulation process. INVO-CELL is designed to only hold up to 7 eggs when you go ahead and put them into that device. So, I mean, if you're stimulating an egg donor and getting 30 eggs, INVO-CELL is not the right tool for you because, there are some anecdotal stories of practices doing that, but there's no data to support that as of yet.
Gotcha. I love
that. I love INVO-CELL because it's a low cost option. And I think that allows people in conjunction with, are you familiar with compassionate care?
A little bit. Mm-hmm.
Yeah. So compassionate care is a really great program that looks at your income and discounts medications based on what your income is. Gotcha. And so, if you can partner INVO-CELL at a low price point with compassionate care, getting discounts on your medications, you can really be complete with your in vitro fertilization process, including your transfer, for well under $10,000, which is almost unheard of in this country.
Yeah.
So for me, that's really exciting because we don't get to offer things like that very often to people.
Right. That's amazing. And are you one of the only providers that offers this, or where else?
There's a handful around the country.
Yeah. Okay.
There's a website and a handful around the country. The interesting thing about INVO-CELL is folks feel very differently about it. And some people's business model has been to price it at the same price as in vitro fertilization. And that doesn't make sense to me. Maybe it does if your IVF is really super cheap, but I haven't seen that be the case. And others have been really successful at pricing it at a much lower price. The other thing that's nice with InfoSolve is you don't have to be there in the office very often. You literally come in for a baseline appointment. You come in for a single ultrasound after 10 days of injections, and you come in for a retrieval and a transfer. So it's 4 visits over 2 weeks. Compare that to your typical injectable and IUI cycle or your IVF cycle where you're in 4 times every week.
Right.
It's just a lot less, right?
I love
so that's why I like it. I've had a couple of patients who travel for it, and that's worked out nicely. And I'm hoping that we can help get that word out to more people in the Bay Area, because I feel like there's a lot of folks here that, if they understood the price point, would be much more excited about trying to have kids than what they're able to do with, the $30,000 ticket.
Right. And I can't think of a better place to go on vacation and have a baby than the Bay Area.
That's right. As long as we stay away from Southern Cal, we're pretty good right now.
Right.
Fingers
pre-COVID, I should say.
Yeah. Fingers crossed that we all find our way out of this. And then I think the other thing that we're doing that we're trying to be really unique about is egg donation options for folks. Because, look, because of all the things we've talked about, there are many women who get to us at a time frame where it's not as likely that they're going to be successful with their own eggs. And, if we think in vitro fertilization alone is bad, the cost of egg donation, traditionally when I started in the practice, it was $50,000 to do, egg donation by the time you paid for the egg donor and the egg donor agency and the lawyers and the this and the that. It was just it was crazy. And maybe it's gotten down to 40, but it's still ridiculous. Yeah. So we started an egg bank, and, we are freezing eggs of donors, and we are making those eggs available, lots of 6 to 8 eggs, depending on the donor and depending on what the couple is looking for. And again, we've been able to price that under, $20,000 for folks. Egg donors typically, like our younger patients, don't need to have embryo biopsy done. So if you want embryo biopsy, that's a different conversation. But the fact that you can make that accessible to folks that would otherwise have to figure out how to, I wouldn't be able to afford IVF with egg donation. Maybe if I didn't have kids, I'd be able to afford it. But, the kids are the most expensive things I own, right? And I don't even own them. But don't use that clip. But that was really a struggle for me, to be in a field where the cost of the service I was offering was more than I would be able to afford. I can't get my head around that. And so, being able to provide donor eggs at a lower price point is really important to us. And so those are the 2 places that I think we've made the most movement in our practice to try and, improve access, right? And I say that knowing that the numbers we're talking about are still not accessible to everybody, right? And I get that. And I wish I could, make that different. There are some things that we just don't have, other than compassionate care. We just cannot play with the numbers around fertility medications. They're just exorbitantly expensive. I know there are people who go and get their meds out of the country, and, I obviously can't be involved in that. But the reality is, sometimes those people get stopped at the border. And then you've got, somebody who's paid for their meds. They don't have the meds. Now they've got to pay for them again. It'd be great if we could handle that aspect of it, but we're not there yet.
Right. We'll get there one day, hopefully.
I know. I'm optimistic. I'm really optimistic. So.
Yeah. So let's talk a little bit about uterine lining. I get this question a lot. How some easy ways to improve your lining naturally? Do you have any little quick tips or anything that you say?
Estrogen. Look, let's talk about uterine lining issues and what we're really discussing. Can you give me a little bit more detail about the types of questions you're getting asked?
Well, I just get that one a lot. I work with clients that are trying to get pregnant naturally, and maybe they're going into their doctor, they're not able to get pregnant. And so they'll say to me, my doctor said my lining was, thin. How can I increase it? Or they're going through an ART treatment, IVF cycle. And they'll say the same thing to me. How can I make my lining thicker so that egg will stick?
So I think those are 2 different topics. So let's do the first one first, okay? Because I think the first one is more of it actually is more of a physiology issue, and I think the term hormone puzzle is apropos. So here's your ovary and here's your uterine lining. Okay, the uterus does not make a lining on its own. It responds to the hormones that are being secreted by your ovary, right? And so often, if you have a lining that's not thickening up appropriately in a natural cycle, what it indicates is that the amount of estrogen that your ovary is able to produce is inadequate to support the thickness of the lining that you need. Okay. And I would argue that the problem isn't just here in that case. It's also here. Because if your ovary is such that you are, making an egg in an environment where the follicular cells aren't producing enough estrogen, that microenvironment is not going to bode well for that egg development, right? And therefore, secondarily, for the uterine lining. So you can see what's happening in the uterus, which is why folks are trying to fix the uterine lining. But the fix is really that you need a better quality egg and a better quality, and the uterus, and the ovary has to do a better job of secreting estrogen, which as we age, it just can't do. Does that make sense?
Yes.
I mean, that's really what clashes, vaginal dryness, irritability, all that stuff is. Right? Those are just all low estrogen states, right? So if you want to fix a uterine lining, then you've got to fix the thing that's providing for the uterine lining, and that's the ovary. Does that make sense?
Yes.
Okay.
Yes.
And if you're doing this on a Clomid or a letrozole, then what's happening is, and for folks that don't understand how that works, letrozole and Clomid both basically block estrogen so that your body thinks there's no estrogen around. And the consequence of that is your pituitary gland turns on and says, oh my God, I got to make more estrogen. It secretes FSH, tells your ovary to do that job. Okay. And now your ovary makes estrogen. And now your uterine lining is trying to play catch up, because remember, we initially blocked estrogen. Yep. So the reason your uterine lining is lagging is because of that estrogen block. Normally, you would be making estrogen when the Clomid is doing its job, and so your lining would have more time to thicken up. So in that case, you have to back end with estradiol which doesn't always work, but the attempt to do that is because you're trying to quickly give the uterine lining the estrogen it needs that it wasn't able to get during the beginning of the cycle when the Clomid or letrozole were doing its job to stop estrogen from reaching the lining.
Gotcha.
Okay?
Makes a lot.
So fix those problems naturally, because the problems themselves are based in the ovary, right? We don't have anything to fix this naturally. The best we can do is give people estrogen, but we're not really fixing the problem. And that's why giving people estrogen and progesterone on the back end to say, when people say, oh, my luteal phase was too short, I need to take progesterone. I mean, you can take progesterone, but what you really need to fix is the fact that the ovary wasn't producing enough progesterone in the first place. Okay. Right? Yep. It's an ovarian problem that you are detecting in the uterus, but it's really a problem with what this ovary was doing in the first place.
Gotcha. Makes a
lot of sense.
Yes.
So I think that
to fix the ovary to get it to do its job is through like an estradiol or something like that.
Well, you fix the ovary by, turning back the clock. I mean, the ovary is acting as it's supposed to in an age-related stage, right? So you can try and push it harder with stimulation medications, right? But on its own, the single follicle just simply may not be able to produce enough estrogen to make the uterus, and then enough progesterone to make the uterus do its job, right?
Yep.
When you're 18, the ovary is a different stage, and it can behave differently. So the other thing is that, not every egg in the ovary is the same. So you're going to have good months and bad months, right? So sometimes you'll have a month where you don't have as much spotting, or a month where the lining gets thicker, or a month where, that's the gamble that you're taking when you're, trying to wait for the healthy egg to arrive and do its job. Do you see what I mean? Gotcha. What you're basically saying is that some eggs are going to be better than others. And we know that. That's what miscarriage is all about. That's what, genetic anomalies are all about. And at a much earlier stage, that's what, cycle length and estrogen and progesterone production and lining behavior is all about, right? So all of this is really about the ovarian aging process. And we're seeing it here in the uterus, but it's not a uterine problem.
Gotcha.
That makes sense?
A lot of sense. Yes. Thank you for explaining that.
As it relates to ART, depends a little bit about and what you're trying to do. If you're in an endogenous cycle where you're, using an intrauterine insemination with injectables, it's kind of hard to fix the lining in that setting if you're not doing it in real time, because you don't have any time to fix the lining. Like you stimulate, you trigger, and now you're doing an IUI, the embryo's there. Like you don't have time. So when you separate things into a frozen embryo transfer and a fresh cycle, you have time to adjust and fix the lining. When linings aren't thickening up over the course of a frozen embryo transfer, there are a couple of things you can do. One is, and by that time you're not natural anyway, so you're looking at different approaches of medication. So some people will do better on patches and pills than they will with injectables, and vice versa. So if you've been on one, switch to the other, right? Some folks are still using Lupron for their frozen embryo transfers, and if it's making your lining too thin, take it away and try without it. Acupuncture, is one of the what acupuncture has been found to do two things, right? Statistically, reduce stress and improve blood flow to the pelvis. So improving blood flow to the pelvis is actually one of the ways in which we can improve, hormones to the uterus, which could theoretically improve your uterine lining, right? So it's a bit of a stretch, but that would be a time where I would say, acupuncture could really, play a role. I don't know a lot of, I'm not an acupuncturist, but I will say that there are a couple of acupuncturists here that we work with very closely, and they certainly have been able to, find some herbal remedies that have been helpful for them as it relates to improving, the receptivity in uterus, right? But, to be clear, herbs are working the same way as the hormones are. They're still hitting a receptor and making the receptor act. And so, you're not, I don't know if that counts as natural, if you will.
Right.
And I think the last thing that has happened to improve uterine receptivity is endometrial receptivity assays, right? Where we are not really looking at the thickness or the thickness or the what's what I'm looking for, estrogen side of this. We're looking at the actual progesterone side of this, and when the uterus is receptive to the embryo by looking at a bunch of biomarkers around these, progesterone behavior. So that's been helpful for folks so that they can be more accurate. We do that now as a standard on anybody who's going through a surrogacy cycle, because by the time you pay that much money to do a cycle, it's just got to be right the first time, right? But the indications for it are if you've had 2 or more failed transfers or miscarriages. I would say people are becoming more willing to do that at an earlier time because, embryos are expensive. So by the time you've gone through 2 embryos, you've spent a lot of money, and now sometimes people are going to be in a position where they have to make a new embryo because they've used up. Yeah. So those are the things, I think the things we've got out there right now for uterine lining behavior, but I don't know that any of them are particularly natural.
Right. Well, that was very helpful. Hey y'all, it's Coach Kayla here. I hope you are loving this episode as much as I am. We will be back in just a minute, but first, a word from our sponsors. Today's sponsor of the Hormone P.U.Z.Z.L.E Podcast is Mira Fertility. How does Mira help track ovulation? Unlike other fertility trackers, Mira measures actual fertility hormone concentrations with 99% accuracy. By tracking your unique hormone levels throughout your cycle, Mira learns your cycle to personalize your ovulation prediction. Because Mira analyzes your actual hormone levels, it gives accurate insights on fertility windows for those with irregular cycles or PCOS. Mira's app synchronizes automatically and eliminates manual charting. In addition to LH and estrogen hormones, Mira is the next step in women's tracking and analysis. Designed to be expandable, the Mira system will offer more at-home health tracking in the future. Mira will measure multiple women's hormones, such as progesterone, FSH, HCG, all with the current analyzer. Mira will help you to achieve your pregnancy goals, regardless if that's trying to conceive, learning your cycle, or trying to avoid. Order Mira Starter Kit or Mira Plus Starter Kit online at miracare.com with promo code Coach Kayla and get $25 off. Mira Analyzer and app take the guesswork and stress out of ovulation tracking. So don't forget to order yours today and use my exclusive code Coach Kayla. Welcome back. Thank you, Dr. Lane, for joining us again.
Of course.
Second half of the show. So let's talk a little bit more about your practice. I know we talked about P.U.Z.Z.L.E, but do you have any other services or, even talk to us a little more about the telehealth that you offer?
Yeah, I mean, we are a full service in fertility practice. We have our own embryology lab, and we do everything from consultations all the way through, pretty advanced third party international care, where we, often take care of folks that are coming from China, from Spain, from Italy, Mexico. I mean, so we take care of folks all over the world, and that's actually, I'm really passionate about international health. I mean, for all of the challenges we have getting good fertility care in the United States, it pales in comparison to the challenges that folks have globally in terms of being able to access care. And, I spoke a lot about women's health, but the truth of the matter is one of the populations that's most challenged to get care are single men and same-sex men, right? And so, yes, same-sex women as well, but, for same-sex men, not only do they have the issues with the legalities of it in many places, but they are burdened by the cost of it because they have no uterus and they have no ovary, and eggs and uteri are the most expensive aspects of a third-party reproductive, cycle. So we are pretty broadly based. We definitely do a ton of telehealth, which is why I was telling you I was so frustrated with my Zoom this morning. Do a lot of telehealth actually, and that's been, there's an element of me that actually may find that telehealth is better as an initial consultation than inpatient consultations, because folks are a little bit less, tense because they're sort of in their own space, right? It's a lot easier to get a couple together. People don't have to take a whole half a day off of work for a 1-hour consultation. So telehealth has been an amazing benefit that has silver lining that has come out of this COVID era. That we were doing already with international health, but it just wasn't the standard in the U.S. for initial consultations, and to be able to transition to that has been pretty awesome. So I'm a huge advocate of that, and I probably do 6 to 8 Zoom consultations a week on top of what I'm doing in my office.
Wow.
And that's probably growing more than anything else. I mentioned we have a donor egg agency. We're super excited about egg donation, and I guess I would love to talk about that a little bit because I think we do it differently. Because we're a clinic, when we are seeing egg donors, we're seeing them not just as egg donors, but also as patients. And what I mean by that is, if you come in and you serve as an egg donor for us, you get a free consultation with me. And, you should get a consultation with me. But the point is that in many cases, the egg donors are not getting information about their own fertility. And so I think it's really important. I saw a patient last week who was, she's 38, and she was an egg donor, or she wanted to be an egg donor, 8 years ago, applied and was denied, and consequently found out when she went back to look that, again, she had one of those low AMHs that nobody told her about, right? And it's one of those scenarios where if whoever had seen her had actually recognized that she wasn't just an egg donor, but she was actually a woman who's going to want to have her own kids one day, and taken the time to explain their, the results of those findings. I'm really picky about that. Explain the results of those findings and give her some guidance in terms of what her next step should be for herself. Even though she wasn't going to qualify as an egg donor, she wouldn't be, in the position she is today. So our egg donor program is really something else I'm passionate about as well. But yeah, we have 2 offices in San Francisco and in Marin, and we do all of our lab work up in Marin. We're starting to collaborate with some other practices around the greater Northern California area to sort of deliver, more care to more places, because there's only one of me and there's only, 2 of them. And so with 3 of us, it's easier. We're just out there to make sure that folks that feel like they either are looking for sort of the intimacy of an individualized practice have access to that, and or folks that are feeling like they've been someplace else and just haven't really gotten the experience that they need, know that there's a place that they can come.
I love that. And kind of walk us through. So say somebody is in anywhere in the U.S., Dallas, Texas, Memphis, Tennessee, they hear this show and they're like, I really want to work with Dr. Danielle Lane. What would your first step be? Kind of walk us through that.
People reach us a variety of different ways. We have a website, and it's pretty basically infertilityinstitute.com. And there's a button there that they can either, make an appointment or request an appointment or call us. Either way, it doesn't matter. People find me on Instagram and they DM me and we get them signed up. If you're an egg donor, there's a link on my Instagram bio. We are on TikTok, as everybody knows. But for the most part, people either reach us online through Patient Pop, which is our online scheduling system, or they call us and we schedule an initial Zoom consultation. Sometimes they're able to get all their information to us in advance. And I think that's the best use of their time if they have access to their records, because, we can do a better job of giving them a realistic view of what's going to happen. And sometimes they don't, they have to gather them, and we are happy to help them if that's what they need as well. And then we, if they're local, we'll see them for an ultrasound and get the blood work done. If they're not local, we will find an outside monitoring clinic, which is, as you know, something we've done traditionally in fertility for 100 years, right? I mean, egg donors are all over the country, so we're really good at finding outside monitoring clinics. We get them ultrasounded, and so that we can get a sense of what's going on in their pelvis. We get semen analyses done. We get blood work back, usually using their own local insurance. And then we develop a treatment plan. And sometimes that plan, it makes sense for them to execute where they are. I think it's hard to do IUIs across the country. And so what I'm finding is that a lot of times, armed with knowledge, women and couples can go back into a fertility space and actually advocate for what they need. And I am more than happy when that happens. And sometimes, like, we have somebody right now who has insurance for fertility. I mean, we are contracted with a lot of insurance companies. And so she's going to end up coming to us from across the country for her fertility, for her IVF cycle, because, we're still going to be able to use her insurance. And, and she just wasn't getting what she needed from that big clinic where they weren't calling her back.
Wow.
So depending on what the scenario is, we adjust and adapt accordingly to make sure that you're getting the care you need in the way that it works for you. We have a team of clinical coordinators. We have 4 of them now, and they work really hard to make sure that everything that we talk about gets executed in a way that works for you.
I love that.
So that's how we're doing it.
Yes, I love it. Yeah. So anybody all over the world can get help through.
Yeah.
I love that. It's wonderful.
It's been really, it's been, again, COVID has had a horrific toll on our country. But a few of the silver linings are that we've gotten, I think, better about accepting, the virtual resources that we have, to make sure that we aren't holding up people's care and holding up people's, family building.
Yes. I love that. So any final thoughts before we close out here?
Well, it's 2021. We're still standing, which is super exciting. I feel fortunate to be one of the folks that I got my first COVID vaccine. My husband got his first. He's an ICU attending. So we're on ready to get our seconds. And so, we feel like we're at least part of getting to that 70% so that we can have some herd immunity. So that's exciting. But I think as it relates to fertility, we are in a space where more and more people are getting information. Folks like you are providing platforms for people to learn about fertility care. If we can just continue to get that message out that, like, don't wait, just go find out what's going on in your body. Like, you deserve to know what's going on in your body. And if you don't like the answer you're getting, scrape together your opinions and at least get the answer to that question. And then we can figure out how to walk you through to the next point, right? And I think that if we can really make that our focus for 2021 and, really do our best to provide access, for services to folks that are struggling to get through their fertility treatment, boy, I think we will have had a great year.
I love that. And I love that you say that, because I talk about that all the time on this show. Be your own advocates. We deserve to advocate for your own health. And so I love that you're saying that. So thank you for that. Yes.
Thank you for having me. It's been such a treat to talk to you. And I just know that I'm happy if you get questions on the back end and you want to shoot them to me, I'm happy to answer those as well. And I'll keep following you on Instagram.
Yes, you too. And we'll have all your links and everything in the show notes. So if anybody listening to this has questions for you, they'll know where to find you. So
perfect.
Yes. Thank you so much. I really enjoyed
it.
All right.
Take care.
Yeah, you too. Thanks for
listening,
everyone. Guys. Until next time. Bye. Hey, hang on just 1 second before you go. I want to make sure that you are aware of all of the amazing free resources that I have for you on my website at CoachKayla.com. From a fertility meal plan, a cycle syncing quick start guide, a holistic healing cookbook, as well as master classes, blog posts by me and some amazing experts in the fields of fertility, hormones, and nutrition. So many wonderful resources that will help you on your journey. And I wish there had been something like this when I was going through my 2 years of infertility, but there just wasn't. And so that's why I decided to create all of this for you. So make sure that you go and check it out and you take advantage of this plethora of support that I have provided for you. And spoiler alert, these were some of the same tricks and the same foods that I used to get myself pregnant, not once, but twice, even after my doctors said that I couldn't. So I know that these things work. Make sure you take advantage of that. And I cannot wait for you to be my next success story. So thanks, love. See you soon. Thanks for tuning in today to the Hormone Puzzle Podcast. Check out the show notes for today's episode at CoachKayla.com. If you like what you hear, please subscribe and leave a review. Thanks for hanging out with me, and I'll see you next week.